All right, let's go ahead and get started. There's mainly some kind of clinical tips and pearls today. Hopefully get done, within an hour or so. This is our agenda. And although the Packers are not making the Super Bowl this year, I figured a quote from Vince Lombardi was appropriate with a Super Bowl season upon us. The winner is always part of the answer. The loser is always part of the problem. The winner always has a program. The loser always has an excuse. The winner says, let me do it for you. The loser says, that's not my job. The winner sees an answer for every problem. The loser sees a problem with every answer. The winner sees a green near every sand trap, and the loser sees 2 or 3 sand traps near every green. The winner says it may be difficult, but it's possible. The loser says it might be possible, but it's too difficult. Be a winner. All right. This is our usual bar graph of volume. You can kind of look at some trends in there. This is 2 months, and you can dig into that more in the notes and minutes from the meeting. These are our daily average censuses by month. So we were 167 in December, 165 in January. We've been holding fairly steady in the low 160s for more than 6 months now. 2% is an average, so it's actually closer to like 2.4. But we did do better in January for left without being seen than in December. That top row there is our admits, and when you add that to the bottom row, which is observation, we continue to be right around 19%, 18, 19%. We've been pretty steady with that percentage for downtown admissions for quite some time. Throughput, if you look at these vertical columns, October, November, December, and then month to date, I took these numbers from 2 days ago. So that's basically January. And down at the bottom in the green circle, the admit decision to bed assigned, we had some significant improvement compared to the month before, but similar to the previous months at 58 minutes. We had a significant improvement in the admit decision to admit time, 127 down from 155. Some of the other numbers were fairly flat in line with previous months. Door to dock times, right around the 19 to 21 minute time from arrival to provider. We had some improvement in the arrival to room time, and this is tied pretty much to volume. So even just that average of 2 patients per day less during those busy times, it makes a little bit of a difference, and staffing also has an impact on this as well. So I think that's why we're a little bit better in January than December. This is the big one. We have new trauma activation criteria, and so I really want you guys to try to focus, as this is probably the most important thing of the meeting today, that we are now having new activation for level 1 and level 2 criteria for patients that are age 70 and older. And so, if you don't have these memorized immediately, remember that this criteria is in the little room behind the HUC where the red phone is. And so you can look at it. And this education is going out to nurses as well. And we're going to go live with this upcoming Monday. So the American College of Surgeons has recommended that there be different criteria, activation criteria for geriatric patients for quite some time. And we've been kind of thinking about this for quite some time. We do have our level 2 certification coming up this year, this summer actually. And so we really wanted to have this in place before that recertification review takes place. And so we're implementing this now. This is basically put forth by the trauma department. The criteria of 70 was, we could have chosen 65. We could have chosen a different number, but that was based on our current admissions, the number that we seem to see as more associated with increased morbidity and mortality for our patient population. So anyway, the new criteria for level 1 activation is BP less than 100. Any sort of instability of the chest wall, including, paradoxical chest movement, obviously flail chest, chest wall deformity, and then a pedestrian struck by any motored vehicle, or anyone who, is in a crash on a bicycle, ATV, motorcycle, moped, with chest or torso trauma. Now, what is the current criteria? Well, that's what this slide is for. So you can see that the difference is, for level 1 criteria for anyone, it's blood pressure less than 90, but for geriatrics, it's less than 100. The chest wall has been added. That was basically taken from the level 2 criteria. The pedestrian struck was taken from the level 2. Most of these things that you see highlighted in yellow were basically taken from what is level 2 criteria for patients of any age, and they're brought forward to the level 1 criteria for the geriatrics. The level 2 activations now includes fall from just as many as 4 stairs or 6 feet, or from a ladder, motor vehicle crash greater than 45 miles per hour, and any head injury at all on any sort of anticoagulant, including aspirin. And again, to compare it to the regular non-geriatric criteria, you can see that on the left, there's a lot more bullets because a lot of those actually move to the level 1 criteria for the geriatric population. That's why there's more on the left, because for non-geriatrics, they're level 2s. But these highlighted in yellow are what you see here as the new criteria for a level 2 activation. And like, I want to also mention, like at the bottom on the left, you see the pregnant patient with abdominal pain or possible labor following injury. That's the latest new addition that we added last summer. Obviously, it's not in the geriatric population. We don't expect a 70-year-old pregnant patient, but I just highlight that because that is our previous newest addition. For those. Does anyone have any questions on this? Well, one other thing I'll add is, the provider does have the discretion to upgrade the criteria if it sounds like a serious mechanism of injury, or if there's something described by EMS that warrants a higher level of activation than these criteria specifically define, then you certainly can do that. But we are held to these criteria by the American College of Surgeons to ensure that we are actually following our criteria. So, we're asking that you not downgrade the activation level. If it meets this criteria, then activate at that level. The other thing to mention is, I think that we all appropriately, care for the time of our trauma surgeons. We don't want them, rushing in, driving through red lights after hours to try to get there for a level 1 activation in 15 minutes if it's not necessary. But we do need to adhere by these, and also consider that when we do activate at that level, that does change things, including billing. Like, it's $2,500 just if you activate level 1 as additional billing, because that goes to the severity of injury and also the facility resources. Questions on the new geriatric activation criteria?
I have one question.
Yeah.
Specifically because I kind of had one of these cases where it was a weird situation. And what I found out was EMS hadn't called in my case that technically would have qualified as a level 1. Does this criteria go out to our paramedics and stuff so that they know to call us like on the red phone and get it started, pre-arrival, that kind of stuff? Because I recently had a pregnancy. Well, I guess charge nurse had like an informal heads up, like a call or a pre-arrival on like just their pre-arrival screen, but there was never a red call from the paramedic. So patient kind of came back into pod 3, and there was never like that official red phone call looking at our trauma criteria, asking questions, that kind of stuff. So does this stuff go out to the field like pre-arrival so that we can get like hit the numbers before they get here and stuff?
That's a great question, and for that case, Kristen, I did look into that, and we did listen to the report. There was a radio report, and they did not specifically mention the abdominal pelvic pain. So we wouldn't have known from pre-hospital information that that was a pregnant patient that should have been a level 2 activation. The idea is that this should be information that is included in a report. So age is included, mechanism of injury is always included, and vital signs are always included. We have done a lot of education with EMS about some additional pieces of information that we want them to include, like last known well for strokes and anticoagulation for any sort of head injury. But it's important for us as we're answering these phones to know the criteria so that we can elicit or solicit additional information. Like, if they say the patient's pregnant, we might want to specifically ask, are they having vaginal bleeding or pelvic pain? If they don't mention the GCS, what is the GCS? So yes, they do get education, and I'll talk to Sherry Verink. I think that this in general goes out, but they probably don't have the exact criteria for all 3 levels of activation memorized for. It's not just all 3 hospitals, but it's also there's different criteria for Blodgett and for Southwest. So we should know the criteria so that we can elicit that additional information if it hasn't been presented. And be aware that nursing can and should activate if they are answering the call because the lead 1 physician is not present and they get this information. They have the authority to activate at this level, even if we didn't take the call. And so the education is going out to them as well. But of course, we try to be on those calls whenever they call in on the red phone.
Okay, thank you. Thanks for looking into that case. I didn't realize there was a call because I don't think there was a physician involved, but I'm glad to know that it didn't meet criteria when they kind of called in. And I guess that leads me to one other question. If at the end of your visit or later in your visit, you realize like something new pops up and they meet level 1, I mean, you can't just like activate 2 hours in.
Yes.
That's kind of what happened in my case. She was like, oh yeah, hey, I have this 2.5 hours into my, like I was admitting. What do you do then? Reach out to trauma heads up? Because you can't go backwards. And
you're supposed to activate at that level. Like for instance, let's say the patient's blood pressure drops and they've already been there for 2 hours. Go ahead and call level 1 activation because now they're hypotensive and now they meet that criteria. Now I realize that you're like, well, do we need the portable X-ray and respiratory? Do we need all this other stuff? If some of that stuff has already been done, their recommendation is to go ahead and activate at that level anyway, because we are held to this criteria. But those are all kind of individual cases, and keep in mind that there are physicians reviewing these, and that's why we review them, to see if there's any opportunity or not. And oftentimes we're just like, yeah, there's not, but they're reviewed for good reason and by good people. So
Okay, thank
Dan,
you.
what was the one about the head injury? So like anybody that walks in the front door that's 70 something that might have just bonked their head, what does that get them if they're on a blood thinner, like a level 2
a
activation?
level 2 activation, absolutely right. That is so. They are our Canadian head CT rules get them a CT scan, but now if they're over age 70, they're going to get a level 2 activation for any bump on the head if they're on aspirin, Plavix, Coumadin, or any of the NOACs.
Well, that seems all right. I guess if they're aware of that, seems like that's going to happen a lot.
They signed off on that, and what we would appreciate is feedback. We every month we have our trauma peer review and trauma operations meetings, and so we discuss these, and they may get revised. I questioned that because what is a head injury? Like, what? How do you define that?
Well,
Is it
I
their
think that should
head
be they should
touched
take out.
something other than their neck,
Yeah.
or is it a cephalohematoma? Is it? So we'll just have to kind of see how we do with that. Any other questions? Good discussion on this. As I said, this is kind of the big one. The other feedback is a couple tips for gunshot wounds to the head. The big one is oftentimes these patients come in and you kind of immediately know that it's a non-survivable injury, but this is just a reminder that in Michigan, more than 50% of the population has filled out an organ donor card. And regardless of what family says or if anyone's there, you can contact Gift of Life early in the process, and they can run the name and determine if the patient is an organ donor fairly early in the process. And so, there oftentimes will be aggressive resuscitation efforts for a patient, even if we, believe that the brain injury is unsurvivable. So don't forget about, Gift of Life and organ donation. Is kind of the first tip. And the second one is, don't forget that head GSWs to the head oftentimes can bleed a lot. We had one case that we reviewed where we ended up ordering a massive transfusion, but it wasn't ordered until, like, I don't know, they didn't get it until 26 minutes after arrival. And I think it was not necessarily known or appreciated by all that there was an EMS report that there was like, a huge puddle of blood at the scene. And then the hemoglobin came back low. So there was like kind of an opportunity for improvement if we had ordered MTP earlier in the process. So their recommendation is to order massive transfusion early, perhaps even in the pre-hospital setting. And then if you don't use that blood, the cooler can be returned. But oftentimes we don't see a ton of bleeding, and we kind of forget about the pre-hospital bleeding and a GSW to the head. All right, any questions or feedback on that? Great. So this is one I was a little hesitant to present this. Tom and I had talked about this, and I think we're on the same page, but I want, this is kind of a part of our ongoing discussion of safety in the emergency department and behavioral health patients. I want to just remind everyone that, we have a policy that our behavioral health patients in particular are supposed to be disrobed and their belongings are supposed to be removed from the room. And there's a reason for that. I'm a big advocate that you should never tell anyone that the reason for something is because of policy. You have to be able to explain why that policy makes sense. Otherwise, we should be challenging that policy from an administrative perspective. So there is a good reason for that. It's because people have stuff in their pockets, and we've had patients pull out lighters and start fires, and people have pills in their pocket and have overdosed in the emergency department, and people certainly have weapons as well. The phones is kind of a debatable thing as to whether they should have a phone or not, so that's why we want their belongings removed from the room, because there can be dangerous items in there. And then we want the clothes removed because it makes it less likely that they're going to elope. It's harder to run out into the ambulance bay in an ambulance or in a hospital gown with no shoes on than it is for someone clothed. So that is the reason. But I think we've all had that situation where you've got somebody that says, if you take my clothes away, I am leaving. And you haven't necessarily done your evaluation yet to determine, do they have capacity or don't they? And you end up negotiating with the patient. So there's also situations, especially for women, where, somebody, hopefully we've all heard of trauma-informed care. So trauma-informed care is, being cognizant that, certain questions, behaviors could elicit a response due to previous, social trauma that the patient has experienced. So obvious example is, somebody who was raped, is not going to respond well to us forcibly removing their clothes. Seems obvious, but we don't know what trauma someone has experienced in their past as well. So we just need to be cognizant of some of these things. And there may be occasions where you feel that forcing them to remove their clothes is going to reliably predict violence or them leaving. And so if you violate this policy, that's okay, but you kind of need to be the one to say, we're doing this, and this is why. This is why it makes sense. And this is kind of big picture thinking. Like, am I going to make the situation better and safer, or the opposite by forcing the patient to disrobe? You might consider, well, maybe, we can offer you scrubs instead of the gown if that makes you feel uncomfortable, or let's take your belongings and your shoes away, but you can leave your pants on, or those kinds of things. Will there be a sitter that can sit there eye to eye with the patient, watching them if they're in a less safe environment because they have their clothes, for instance? So I'm not authorizing you guys to just have at this, and I certainly don't want to cause a slippery slope where the nurses begin violating this policy and without the authority of the providers. I'm just saying that kind of we support you in looking at the situation and making your best decision based on the information you have and what you predict will happen in the future. So that's it. Obviously I present these things because of situations that we've had, and we've had situations where forcing someone to disrobe induced immediate violence or someone leaving. And we've also had numerous instances where someone was not disrobed and they had something on them that was dangerous and made the situation. So we've gone both ways. Feedback on this. I think we've all had stories that we could share about this one way or the other. All right. Respiratory. I had some feedback from respiratory. Basically, just a reminder that we haven't changed the policy on our multi-dose MDIs for PUIs. So way back in the pandemic, we defined nebulizers as an aerosolizing procedure. And so we started using these multi-dose meter dose inhalers. And I think we've kind of gotten away from that a little bit. I realize that our COVID numbers are much, much lower than they had been previously, and that the kind of the mortality associated with COVID is also not the same as it was in 2020. But we still haven't changed that policy, and so respiratory is asking that we do consider that. There was a time where we had some limited availability of the Atrovent, and I think most of us do give albuterol and Atrovent in most instances. But I've checked with pharmacy, and we do have an adequate supply of the Atrovent. So you can give the MDI. Typically, it'd be like 4 puffs of albuterol and 2 puffs of Atrovent in lieu of a nebulizer. You can still do the nebulizer if you think that it's appropriate and you think it's going to be a better delivery method, or if you think they need higher doses. But just be cognizant of it. Don't forget the meter dose inhalers. The other thing is, I don't think that this is much of a big deal. I just mentioned it kind of in passing. Respiratory had noted a couple, several doses that had been ordered of like 10 milligrams of albuterol, Q15 minutes times 3. Not necessarily unheard of in a severe asthma respiratory failure situation, but it's a pretty high dose, 30 milligrams in 45 minutes. Each of those cases, and there was only like a couple of them, was ordered by a resident. So just keep an eye on your resident orders, and not completely unheard of, but higher than we, I think, usually order. So just keep an eye on them. Any additional comments or feedback on respiratory issues in general? All right. I'm part of this utilization review committee where we kind of go over mainly criteria for inpatient and our patients staying too long or too short. Are we getting appropriate billing and all this stuff for the entire hospitalization? And so we're doing a little bit of an update, and we talked about this a little bit previously in some emails, but I wanted to mention it in the meeting that we are having a little bit more instances of patients being admitted to inpatient that then get converted to OBS, and that's always a bit of a dissatisfier for the patients. So all these criteria are pretty complicated, and it's not really our expectation that we know all of the admission versus observation criteria. So we have to just kind of do the best we can. And so this is just a couple suggestions and tips of the ones that we have seen more frequently get changed. One other thing is, please remember to actually tell your patients that they are being admitted under observation status. And I've said, try to avoid actually using the word admit, because when they hear the word admit, they think inpatient. So we want you guys to say, we're placing you in observation status. You'll have a bed in the main hospital. That means we expect that you'll, stay, less than 24 hours in the hospital. And then, if there's questions as to why, they say, well, there's, criteria that define each. And if you, if you meet inpatient criteria while you're in the hospital, then your status will be changed. So anyway, the main diagnoses that we're typically getting switched are chest pain, encephalopathy, any psych has a primary diagnosis, weakness, and TIA. So, if it's not ACS or unstable angina or non-Q wave MI or, positive troponin, any sort of chest pain rule out should be observation. The one that perhaps I wasn't as aware of is this encephalopathy, and often that's an altered mental status. So that's another one that frequently gets flipped. And then hopefully we're all aware that whenever we're doing our kind of boarded psych patients, those are always OBS. If they're, waiting psych placement, 100% OBS. And weakness. That one's kind of tough because oftentimes they're coming in for like SAR placement and they need that 3-day inpatient stay, but they just generalized weakness just doesn't cut it. And TIA is usually gone within 24 hours. So those are the 5 ones that were kind of most on the list. Other ones to consider, TIA got there twice, but palpitations, back pain. Two that were news to me was appendicitis and cholelithiasis with plan for laparoscopic surgery, because they actually typically go home in less than 48 hours. Iron deficiency anemia, hyperglycemia without DKA, so type 2 hyperglycemia, type 2 diabetes, migraine, vertigo, orthostatic hypotension, and UTI. So I'm not sure why we'd be admitting UTI anyway, unless it's a complicated UTI. So those are the other ones listed. Questions on this? All right, we're making good progress. Pearls from OBGYN and preeclampsia. We have fairly regularly, I meet with OBGYN to just kind of coordinate care. And I think in general, we do a pretty good job. Within the last year, we initiated that OBGYN emergent pager for like emergent deliveries. That's been used a few times quite successfully. So just some feedback. Before we got a pretty strong push to basically be more aware of potential preeclampsia and specifically postpartum preeclampsia, and to be more aggressive with calling OB and starting treatment and such. We've had a few cases where maybe the pendulum has swung a little bit too far, and we've started some magnesium on patients that retrospectively were kind of like pre-existing hypertension, or that didn't meet the full criteria of the sustained blood pressure greater than 15 minutes. So this was just some feedback. I think the take-home message for this is continue to be on alert for preeclampsia, postpartum preeclampsia. Look closely at the vital signs of your postpartum or third trimester pregnancy patients. Ask that they get repeated in a timely manner, and then discuss with the OBGYN early in the process so that you can kind of coordinate the lab workup, and then to discuss, if you think you're ready to start MAG on a patient, it's probably best to connect with OBGYN on that to coordinate that care, unless they're like having a seizure or something like that, and then obviously you need to treat. The last thing is we have this pretty good job aid. It's on our SharePoint website. It hasn't changed. It's a flow sheet, and it shows you specifically, like systolic greater than 160 or diastolic greater than 110. This is what you do. Systolic 140 to 160 and diastolic 90 to 109. This is what you do. And then systolic less than 140 or diastolic less than 90. This is what you do. It has the 15 minutes sustained in there. And then the other side has this checklist. It shows your magnesium order, 4 to 6 grams over 20 minutes. It has a list of all the labs you should be ordering. It's a pretty good, quick and easy reference, and it's on our SharePoint in the clinical aids library. That's it right here. The last suggestion that they had was they really like the 6 grams of magnesium rather than the 4, unless it's just like a teeny tiny person. But most of our order sets and even this checklist says 4 to 6, so it doesn't specifically say. So that's just another thing to kind of coordinate with OB. Any OB additional feedback or such? I might mention that case that Kristen was talking about with the trauma activation. They did activate OB, and OB was present before the patient arrived, which was perfect, absolutely perfect. So when they call, they do come running. That's good. Okay, RHIG. We've had a couple cases now where we've missed giving the Rofalac, which is just our brand name. We changed from Rogam to Rofalac. It's the same thing. It's RHIG, where we missed giving it to a patient that should have gotten it in the emergency department. So that's the update on this. Just a reminder, and it was an unusual case, but as a reminder, so it's any bleeding during pregnancy, which is kind of the definition of a threatened AB, miscarriage in progress, obviously. Those are the obvious ones that we think of, but also missed AB or fetal demise, even without, cramping, even without vaginal bleeding, those should also get it. And the logic is that, they could start having that miscarriage, like an hour after they're discharged or such. And then pregnant trauma patients also. Those ones you probably want to coordinate with OBGYN, because sometimes they want to do that Clahau or Becky test and do a specific dose. But if it's like a first trimester, then it's going to be the standard dose. So, and Tom, you're on. I don't know if you want to talk about this next section for Southwest, or you want me to just go over it.
Yeah, I was just going to email it just so people can read it, but if you want to go over it, then that'd be okay too. I think it's probably easy enough to read. But
yeah, it's kind of stupid, but once we determine that a patient is Rh negative, then we know that they're going to need the ROGAM, but they also need this type and screen because they do additional antibody screens that really don't affect the ROGAM dose, but they do affect like what they do during pregnant or during delivery and then after. And so Epic has built in this logic where they will not let you order ROGAM until a type and screen is completed. And Southwest can do the Rh factor, but they can't do the blood screen. And so at Southwest, they will know the Rh, but then they're going to courier the blood downtown to complete the screen, and you will not be able to order the Rofolitic until that process is completed, which obviously can take hours. When you order the antepartum Rh evaluation, you will get a pop-up that says this is an RHIG candidate, and then that's the only way you can order it. If you cancel that, you cannot order it. You have to order it from that pop-up. And that pop-up won't pop up until the type and screen is completed. So it's the same process downtown, but because the type and screen happens much faster because the lab is downtown, we just deal with it. So just be aware of this. The work around it, if somebody absolutely can't stay for that extra time, you could technically call one of the ED pharmacists on the phone and ask them to do an override order. Once you're sure that the patient is RH negative, you could do an override order and have the pharmacist order it through their Willow application in Epic, and then it can be released. But again, that checks and balances there for some reasons, but that's
Just to
that's
add
the
on, all the pharmacists are aware of that, and they're willing to order that workaround, which I did last week because it was taking too long. So they're all willing to do that. I don't want to say do that every single time, but some patients just can't wait 2 hours. So they're willing.
right. And of
I-
course, we've complained about the process, but it's just not changing. It wasn't set up acknowledging that there were standalone emergency departments that wouldn't have type and screen. Someone else had something?
Yeah, I was just wondering why in general, like, we have to go through this whole process. Like, what is the point to somebody who's had, 8 RH negatives in the computer? You can just look it up and just know that they need to get prophylactic. What's the point?
I asked that same question, and as far as we're considered, it shouldn't matter. But there actually is some complex reason if you're an OBGYN, you would know, and it has to do with like the antibodies, because they do something a little bit different if they determine that the patient has like these kind of rare antibodies. And that's why they want a type in screen. And I asked, well, what if they've already had one? They're like, no, it has to be like this pregnancy. The OBGYNs, they don't have to deal with this in the outpatient setting because they order a type and screen in before the 28th week, and so they're able to just order the ROGAM, but it's because they've had that type and screen at some point during the pregnancy. All right. Notification of guardians. I sent this out by email, but I wanted to highlight this because we are having a ton of problems with this. There's like some sort of legal patient rights violation being levied against the hospital because we keep failing to notify legal guardians. Um, so this is just a reminder, take a look at the storyboard. It's a little easy to miss. It's right there, kind of under the name, under the full code. It's highlighted here in red. And oftentimes, if there's a complex care alert that pops up, it's usually listed in the complex care as well. But this is easy to miss, and that's why we're missing it. If somebody has a legal guardian, then you have to treat them like like a 13-year-old child that showed up and registered to be seen in the ER without a parent. We need to notify the guardian and obtain consent for treatment just to be seen in the emergency department, and we need to notify again if they're admitted. And then we also need to notify them if they have, a major procedure that would require like a signed consent, like a appendicitis or something like that. So those are the three circumstances. So we are in the process of undergoing nurse education for this. The request is going to be that nursing do the notification when they identify that the patient has a guardian when they're registering the patient, which could be out front, or it might be for an ambulance patient back in the main ED. The ask for us is to just be aware of this, and there will be circumstances because many of these are legal guardians that are, it's like somebody that has like 60 or 70 people that they're the legal guardian for because they're assigned by the city and they get like a small amount of money for being their legal guardian. But these are not often like family members that are super involved. And sometimes they don't answer the phone. And so, there will be instances where despite an attempt to notify the guardian, it hasn't been done. And so we need to be aware of that as we're, going through the ED process, especially if they get admitted, of, making social work available, perhaps if, or the admitting team that, notification processes need to be ongoing. Questions on that? All right, most of the other stuff I send out by email, logistics type stuff. Is there any questions on anything you've already received in the last month since the last meeting? 2023 documentation, resident stuff, anything else? Open discussion, floor is yours. Going once. All right, I'll send this out as a recording. Looks like we got done in about 45 minutes, which is great. And obviously, send me any questions, call me on the phone, text, whatever, if you have any questions at any time. Otherwise, have a great Wednesday. That'll do it.